session. This webinar is being recorded and will be made available to you all. We would love to hear your feedback, so please hang tight at the end so that way you can fill out the brief evaluation at the end of the session. We will provide you a QR code that will take you directly to the evaluation. All right. So I'd like to briefly mention NACC strategic pillars. These pillars are guiding the work at NACC as we chart a path forward towards equity. Much of the content in today's session is aligned with the pillars. If you'd like to learn more, if you'd like to have more information on the pillars, please feel free to visit the NACC website. All right, so in terms of our session presenters, you will be hearing from myself, Chloe Destinoble, and I am at NACC. And then we will hear from our colleagues from KKV. We have Megan and Allison, and then we will hear from our colleagues at ODFMC, Karen, Sarah, and Leanna. All right. So in terms of our learning objectives for today, we want to, one, gain insights on the critical importance of nutritious foods, access, and how food insecurity disproportionately affects communities nationwide. And two, we want to explore promising practices and gain insights from successful programs across the country addressing food insecurity and meeting nutritional needs. And then three, we want to discover how strategic partnerships with both community organizations and corporations can provide sustainable opportunities for the growth and maintenance of food and nutrition security initiatives. All right, so we think it's important to start with some level setting. So we want to talk about what are social drivers of health and why are they important? There are several ways to spell out the acronym SDOH, but they all point to the same thing. These are non-medical factors that influence a person's health outcome. These are the conditions in which people are born, grow, live, work, play, and age. These conditions are shaped by the distribution of money, power, and resources. SDOH is neither positive nor negative. Each person, either positive or negatively, that can be positively or negatively affected by social drivers or determinants of health. As the driver of health inequities, social drivers have shown a greater impact on a population health and individual well-being than factors such as biology, behavior, or medical care. Medical care, although essential for health, has shown to account for only 20% of healthy outcomes for a population. The other 80, 90 have been attributed to the social, economic, and environmental factors referred to as the social drivers of health or social determinants of health. So we were going to get into a video, but during some testing, we realized that it's not working. So what we will do is go ahead and share the link to the video for you all. And we do encourage you to take some time out to watch it when you get a chance. But essentially, in this video, it describes like what determines how long we live. Your zip code essentially is more important than your genetic code. So in the video, it's demonstrated we have Deb and Marie. They live in two different towns. One will live 15 years longer than the other because essentially of where they live. You have town A and then you have town B. Town A has more resources. They have access to nutritious foods, the markets, and so on and so forth. But then you have town B that is essentially a food desert. The person who lives in an area such as, I believe it's Deb in the video, and a town A, because of the fact that she has access to sidewalks, to access to fresh foods, versus Marie, who lives in town B, who doesn't have access to fresh foods. There are a bunch of liquor stores, fast food restaurants. You have Deb will essentially live longer than Marie just simply because of their zip code. So your zip code is a predictor of how long you'll live. The US life expectancy is 43rd in the world, and it's still dwindling down, and it seems to be correlated to inequities. But I did go ahead and share the link in the chat for you all. So when you do have some time, we do encourage that you take a look at it because it's very informative. All right. So continuing with the theme of level setting for this webinar, before we hear from our colleagues, so we think it's important to identify some key definitions. So in terms of food insecurity and hunger are sometimes used interchangeably in conversations around nutrition. Security is really coming to the forefront in this space. Food insecurity is a household level economic and social condition of limited or uncertain access to adequate food. We consider a household to be food insecure if all its members at all times has access to enough food to live an active and healthy lifestyle. And here we're really thinking about getting enough calories in. Hunger is a potential consequence of food insecurity that results in discomfort, illness, weakness, and pain that goes beyond the usual uneasy sensation of being hungry. And this results from not having enough to eat for an extended period of time. So when we use the term hunger, we're zoomed into more of the individual level and what's experienced in the body. So we know through that there is a strong association between food insecurity and poor nutrition, with individuals who report being most of food insecure also at a higher risk of developing diet-related diseases such as obesity, diabetes, and hypertension. While food security focuses on ensuring that everyone has enough to eat, nutrition security ensures that everyone receives and consumes calories that contribute to their overall health. And with that, we're thinking about consistent, equitable access to healthy, safe, and affordable food. Nutrition security initiatives often include a food security component addressing both the quality and the quantity of the food people have access to. So nutrition security initiatives are really gaining traction and coming to the forefront of this work. Right. So, in terms of food insecurity and equity, according to 2021 data from USDA, so this is a bit dated, it's estimated that nearly 34 million people, including 5 million children, experience food insecurity nationally. We know that this number really grew with the rise of COVID-19, but food insecurity was really prevalent prior to COVID and remains one of the top social risks nationally, but essentially for health centers, patients, even as the pandemic has waned, causes of food insecurities include poverty, unemployment, underemployment, or low income, lack of affordable housing and or transportation, which often results in a lack of access to food or trading off paying for food or pay rent. Chronic health conditions or lack of access to healthcare, again, prioritizing healthcare costs over food costs in many cases, or folks are not well enough to get to the food they need. And systemic racism, racial discrimination, which shows up in all the causes mentioned above and colors what the food landscape in a community looks like. Food insecurity disproportionately affects communities of color, with Black households nearly 2 times more likely to be food insecure, and Hispanic or Latino households approximately 1.5 more likely to be food insecure than their white counterparts. It's estimated that about 23.5 million Americans live in a food desert where grocery stores or other food retailers with fresh, healthy, and food options are inaccessible or unaffordable. And we know that food deserts are more likely to occur in communities of color. So now to get into the linkage between food insecurity and chronic disease, those experiencing food insecurity are 32% increased risk of obesity. They're 2 to 3 times more likely to have diabetes, and they have 21% increased risk of hypertension. And what many of you surely see in health centers is that food security and chronic disease operate in a continuous cycle. The cycle begins when an individual or family can't afford nutritious foods, as illustrated by this diagram. The combination of stress and poor nutrition makes disease management challenging, and the time and money needed to respond to the health condition strains the household budget even more, leaving less money for healthy food and medical care. This causes the cycle to continue, increasing the risk of these conditions getting worse, and for children in a household to develop chronic conditions themselves. We know this makes it really hard for folks to get ahead and get healthy, essentially. And that's why the work that health centers and community health workers and community partners do is so critically important for our families and individuals experiencing food and nutrition insecurity. All right, so before I pass things over, there are a number of national efforts really gaining momentum in the food and nutrition security space, but a couple of highlights. Spearheading this is the White House Challenge to End Hunger and Building Healthy Communities. There's a lot of energy and partnership happening here, and I'll direct you all to the Community Action Toolkit and Implementation Guide as well. I will also provide all of these resources to you all towards the end. We're seeing more and more states using funds made available through 1115 waivers to support nutrition education and food and nutrition security programming and partnerships. Payers are increasingly interested in this work, not only because of the nation priority, but also because food and nutrition security program is an impactful and gets high engagement from patients, and foundations are increasingly looking to support this work, and partnerships needed to make food programs possible. We're seeing a lot of cross-sector partnerships as well for food initiatives between government, healthcare, transportation companies, community-based organizations, and others. The Vital Conditions Framework, which is utilized by the Federal Plan for Equitable Long-Term Recovery, provides an organizing structure to build connections and alignment across federal agencies and sectors. As this is implemented, it's really to facilitate depth of the partnerships engaging in food security work. They have some really great food-related resources that you all should check out, as well as that's linked in the slides for you all. Again, I will provide a copy of all of this for you all to have these links available. And lastly, the SDOH team as NACC is collecting stories from the field. We want to know what you're doing to address food and nutrition security in your community. We ask that you scan the QR code and share what you're doing at your health center or with your community partners. It could be programs, big or small efforts, but this helps us paint a picture of what health centers are doing nationally and connect health centers with each other to share learnings. So definitely take a moment to fill out that form. The QR code is available to you all. So with that, I will go ahead and pass it to our colleagues at KKV, who will continue this presentation.
Aloha, everyone. My name is Megan, and I'm the Research Director at Kukua-Kaliki Valley Comprehensive Family Services. And I'll be presenting with Allison. Allison, did you want to introduce yourself?
Oh, hi, I'm Allison. I'm a research assistant at KKV.
Awesome. And so I want to make sure we don't run over time, because since we're the first one presenting, and so I'm going to start my little timer, and we're just going to jump right in. And I know our title is kind of lofty, right? Healing our food system. But that really just grew out of this conversation we had with our leadership about where we wanted our food security and sovereignty work to go. And we knew that we had to work both directions, right? We had to work from the bottom up as well as from the top down. We needed everyone at the table. We had to have community, farmers, doctors, politicians, everyone who makes up our food systems needed to be a part of this solution. And so we haven't checked that box off. We haven't healed our food system yet, but it's our goal. And originally, Allison and I were just going to talk about one of the food programs that we have been involved with. But we wanted to challenge ourselves, because I think at KKV, we've gotten pretty good at telling the story of each of our programs and the impact it has. But our goal as the research department is really trying to weave those stories together, right? What is KKV's, what is all of our food work, and what is our collective impact? And to be honest, this is a work in progress. You know, we went around, we talked to everyone, we collected data, and this is what we got so far, but I'm really excited to share it with you folks, and I'm excited to continue the conversation after we present this. Okay, next slide. Oh, that's us. Next slide. Okay, so just to tell you a little bit about our community, we serve the community of Kalihi, which is an area in Honolulu, Hawaii, on the island of Oahu. Just to give you kind of a picture, we're home to the 2 largest public housing developments on the island, so a lot of concrete. But every day when I drive to work in the back of the valley, it feels like you're going through a jungle and there's chickens running across the road. And so really there's both. There's like this very urban setting as well as rural. And historically, Kalihi has been the first home for those immigrating to the island. And today it continues to have a rich and diverse culture. A lot of our patients reflect our community, right? And so we have a very large population of Asian and Pacific Islanders, and a large population of people who prefer getting their care in a different language other than English. And we like to tout that we have staff members who can provide services in over 27 different languages at our clinic. I wanted to share this compilation of quotes that we collected of community members describing what they love about Kalihi. And I think this is so important because from the outside looking in, oftentimes Kalihi is described as being poor or even dangerous. You know, like Chloe described, probably we'd be town B in people's eyes, right? But when you're on the inside out, you feel the connection to abundance that lives in Kalihi. Right. And so people said, I love how proud people are to be from Kalihi. We are tough and kind. We care for one another. We have many cultures and we each hold our own wisdom and skills. Kalihi is home and gives me a deep sense of belonging. Right. Okay, next slide. And KKV is a place-based clinic. And so we serve those in Kalihi, living in Kalihi. But once you are a member, you're a member for life. So a lot of our patients have moved all across the island, but they continue to get their care at KKV. And we like to tell our genealogy story, right? Because the first staff members and a lot of our staff members today continue to be from Kalihi, right? We were built on our super aunties. And these are the strong women in our community who take care of everyone, right? And so in the very beginning, 50 years ago, they went door to door and just asked people, how are you doing? What's going on in your life? How can I help you? And listening deeply to the people they were talking to, we started with dental services because we learned that oral health was a big issue in our community. And today we try and honor that deep listening, that following our community, that knowing, truly believing that our community knows the answers. We just have to listen and follow. And I'm so honored that I got to interview some of our super aunties. And one woman said, we didn't do anything special, but we served the community and we served ourselves by accepting each other's culture, the good and the bad. And it's so simple and it's so hard to do, right? Next slide. But we continue to try and do it at KKV. And one of the things I love the most about KKV is that we have many different healing modalities, right? You can get your teeth checked, your eyes checked, you can see a psychologist, the doctor, but you could also fix a bike. You can work in our community gardens. You know, one woman said, sewing is my medicine, and she was in our sewing group, right? So it's just like that picture that Chloe showed in the beginning, that medical care is, I think, 20% of our health, and social determinants is that other 80. And so we have programs that really address all of them. But I think the thing that is the same throughout our programs is our process, right? That we're always trying to listen deeply to the person in front of us. And it sounds really cheesy, and I get nervous saying it out loud, but really all you got to do is love the person in front of you, right? If you love your community, if you love your patients, you're not going to quit until you work together to find a solution, right? And one thing I love about us is that we're very relationship focused. And that can be hard to do because I know everyone has so many stressors in their life. Oh gosh, like doctors have to get through all these things in a 15-minute increment. You know, our CHWs have lists and lists of questions that they have to answer. But we really try hard to put that aside and listen to the person in front of us and build trusting relationships. And trust that once that relationship is there, all those surveys, all the other things will be easy to do, right? And our goal is always equitable, culturally safe access, right? We believe that no one should have to leave their culture at the door to get the care that they deserve. And the care that we provide is always aimed at dignity and agency. I think oftentimes we ask patients to prove that they deserve care somehow or that they're needy enough, and that erodes at your dignity. And so we truly try and stay away from that. And we also know that people want to take care of their families. Nobody wants to ask for help if they don't have to. And so we're always trying to build people's agency. And one of our super aunties said, that's the resilience. People keep coming back. Generations keep coming back because they feel like this is a place where they're cared for, right? And so that's our goal. Next slide. And so today is all about food. And so we wanted to give you kind of a brief overview of the history of food and land in Hawaii. And Allison will give you more details.
So back in the beginning of time, which is not actually that long ago, Hawaii was full of abundance, and pretty much the land takes care of the people as long as the people take care of the land, and it was self-sustaining. So in Hawaii, each island has their own ahupua'a system, which goes from Mauka, which is the mountain, to Makai, the ocean. And within that ahupua'a system, you are self-sustaining. And over time, like with foreign arrivals, the foreign ships brought animals, plants, and even food that disrupted our ecosystems. And a lot of our native like birds and plants are now endangered or are now extinct. And that's just the reality, I guess, of it. And then with the plantation era and industrialization, a lot of it went from green to concrete, which we currently see now. And now, like current day, we're trying to return back to the ancient practices of just taking care of the land and having that full of abundance everywhere. And then the quote to the right is from a Kalihi resident, where she's recalling her dad's perspective on what Kalihi used to look like, where it was full of abundance. And the ending part of it says where the coastal line was alive, and especially the reef runway, right before it was dredged up and made for development of where the airport now sits. Next slide. I think you're muted, Megan.
Sorry, thank you. And so we went around and asked people, why do you do this work? Why do we do food work at a health center? And it's because we know food is medicine, right? And I think it's also in the other folks' presentation, right? This is a common knowledge. Because we know that food nourishes us. It can be a powerful medicine to heal our illnesses and keep us strong. And that good food, when it's grown with love and dignity for both the land it's grown on, as well as the people it's grown for, can heal our spirits, right? Food can connect us to each other, our memories, our cultures. You know, I'm sure if I asked you guys to close your eyes and think of a meal that your grandmother cooked for you, or your mom, or your auntie, or your dad, you know, that would bring you back to that time, right? And I know for myself, as a fourth generation Japanese American who can't speak Japanese, food is the strongest tie that I have to my culture. And my family, we hold on to those recipes that my great grandparents brought over, right? That is our connection to our culture. Food also holds space for us. It inspires us to share. We have it when we celebrate, when we grieve. You know, it can open up conversations. And so these are all the reasons why we do food as medicine. Okay, next slide. And unfortunately, we also have food insecurity in our community. And so Allison's going to share a little bit about that.
So what Megan was saying, that at KKV, we build relationships with dignity and agency, even though we have questions that we need to ask, like the SDOH question, how often do you stress or worry about having enough food for your family? And it's a Likert scale that we have patients answer. We don't ask that just like that. We kind of weave it into a open-ended conversation style where patients feel that they can share more of what's going on. Because there's always more things than just, I need food right now, that are affecting a household. And so we always try to remember that and take care of each other within the community. And as you see, over half of some of our patients have some level of stress, and less than 10% worry every day. Hopefully one day no one has to worry, but that's like a big dreaming thing. And then actually, from just asking and having open-ended conversations, I had a patient who came to pick up food. They needed food support, and just greeting them like, hey, how's it going? They opened up and shared, like, they both work in the restaurant industry and they just received a $1 pay raise, like $1 per hour pay raise. And because of that pay raise, they lost their EBT food stamp benefits for their whole entire family. And that was their like main source of reliability of food. And so because of that, the rest of their income went to paying rent and bills that they weren't really sure of how they were going to feed their kids and the rest of their family. But that wouldn't have come out if I just had asked the question flat out, kind of thing. And so even just having families that come to pick up, most of the average household in Kalihi is about 8 to 9 people. And so I know there's rules that we follow, and Auntie Rebecca, who used to run the housing and food program at KPT, which is Cohio Park Terrace, which is one of our largest public housing, had said that even though she sees multiple people in line for like food pickup, even though the rule may be 1 per household, if they're standing in line, she honors that and she gives each person that's in line, because there's clearly the need for it. And even today, like for me personally, I honor that because I personally wouldn't do something that I wouldn't need. So if I see people that are there, I honor that, even though I know there's like 2 of them from the same household. Next slide.
Okay, Chloe, I just wanted to confirm, Chloe, we have 15 minutes for our presentation. Is that correct? I can't hear.
You have about 25 minutes. You're fine.
Oh, okay. Okay, good. I was like, okay, we have 2 minutes. We're going to get through the rest of the slides, but that's great. And this is kind of our what slide, what we do. And this could, I don't want to bore you guys. I could just list on and on all the things we do, but we do everything from feeding our elders. You know, during COVID, we delivered a lot of Ensure to make sure that people had the nutrition that they needed. We also have a medical nutrition department who really works with our chronic disease patients. And they do everything from going shopping with the patient and teaching them how to read the nutritional values on the back of packaging, as well as cooking lessons, right? And I love that they do everything from introducing new types of produce to saying like, hey, these are the cans that you get in your food bank box. Let's cook with them. What can we make, right? And so really meeting people where they're at. We have Holuaina, which I mentioned earlier. It's our 100-acre nature preserve, and they grow food, forest, and medicine. So there's a lot of plant medicine that our community can access there. We also have the Roots program, which has a cafe and a food hub and sells produce. They work with our farmers, and they also do a lot of work with policy. And so looking with other organizations to address food security on a larger picture. And then lastly, we have Huihuaka, which was our community emergency response to COVID. And now that COVID is fading away, we really want to continue to try and be that safety net for folks, even at our clinic. Maybe they don't fit into all the other programs, but you will always fit in Huihuaka, right? But what I heard that was the same throughout all of our programs are kind of these 5 overarching food strategies, right? We're always trying to connect people to culturally relevant, locally grown produce. This is so important for us in particular, because we went from an island that could feed everyone living there to, I think the last thing I heard was, if we stopped all shipment, we could only survive for 3 days, right? That's how much we depend on outsourcing. And so we really want to go back to our roots and farm more and feed our own people with food that's grown on our own land, right? And we also want to connect people to the land. We know that land can heal. And so we have a lot of community gardening, and even just like we have a diabetes group, and the doctors will take them out to the garden, and they say the conversation just opens up so much more than when they're in the clinic in a different way, right? And we're always trying to connect co-learning and resourcing. And so what I mean by that is, we could give away all these resources, but if we don't collect data on it, then we won't know the impact. We won't know if it's working or what's not working. And at the same time, we don't want to just extract and survey all of our patients and collect information. We really want to connect both together, right? And I like the term co-learning, just because I really truly believe that our community is teaching us, and we have things to teach our community. So really, it's the mutual healing. And I think just like everyone else here at a community health center, we like to go broad as well as deep into each individual. And lastly, we're always trying to get better at integrating our data. And we have some examples that we'll share soon. Okay, next slide. And so this is kind of our impact. This is our indicators of success. And we just focused on 3 of our initiatives. So the first one that I'll talk about is our Huihuaca community COVID response. And that was just when the shutdown happened, we wanted to ensure that our community had all the resources that they needed to stay safe. And we just started calling on them on the phone. And what we learned was, yeah, in the beginning, everyone was healthy, but a lot of them were furloughed. And so people living on the edge were now pushed over, and their cupboards were empty now. And so the first thing we did was start doing deliveries, right, of produce as well as other types of food. And so we did almost 20,000 prevention deliveries, and then COVID hit. And what we were really concerned, because we had the potential to have a crisis, right? We have a lot of multi-generational families living in small homes where the COVID could just rip through. And so we really wanted to protect our community. And so we did almost 12,000 COVID deliveries. So these were providing enough food for people to safely quarantine at home. And I guess, so I could keep going and going about all the things, but really what was important was, sometimes when I describe Huihuaca, people walk away and say, oh, you guys were a food delivery program. And we're like, oh, it was a little bit different, because it's not just about the food. The food is important, but it was also about relationship. Right? It was the person calling them on the phone. It was the delivery team with a smile. It was the love and care that the boxes were packed in, right? So if we knew it was a Filipino family, our staff would put in produce that they knew Filipino families love, like eggplant and manungay, right? And so there's a lot of care that was put into that. And I think that was the healing part, right? Not just the food. And we saw it, the impact, when it's done like that, there's a reciprocal excitement and healing happening. Every time we did a delivery, people would want to give our staff, homemade masks, or they would say, oh, thank you so much for the food. I shared it with all my neighbors last time, so there's this ripple effect of giving and caring for one another. Yeah. Allison, did you want to go into the other one?
Oh, okay. And then because of COVID, we started a program where we were asking people, like, are you, after you came out of quarantine, how are you doing? And just as a checkup. And a lot of the families still said that they were food insecure and or they tried to apply for government assistance programs like WIC, EBT, but however, they did not qualify. Either they made too much or too little bit, and that still prevented them from accessing food or even going to like food banks. But certain food banks ask for like a bill or a proof of residency, and some people don't have that, and that automatically disqualified them. So with Huihuaca, we had a food support program where we didn't ask people to prove that need. It was just, you need food, can you come pick it up? And how many are in your household? So we can feed your whole household. And because of that program, which was from August 2022 to July 2023, we served just about 7,500 patients, like unduplicated. Next slide.
And this graph is so exciting for us. It's so simple, but it took years and years and years and years. And it's this idea of putting our social determinants of health data together with our clinical data. And Ali, were you going to talk about that?
Yes. So like Megan was saying, a success was integrating data with medical and like just needing produce, for example. But how do we show that to like all types of perspectives, like a medical, a funder, or just even to other patients as a share back so that they know that they're not alone. So this is really exciting. The Produce Prescription RX program, which allows providers to actually write prescriptions for patients with chronic diseases such as hypertension and or diabetes and other chronic diseases, to receive produce, fresh produce once a week. And as you see the chart, where it shows the medical side, but actually we shared this chart back with the farmers who grew the produce, and the farmers' feedback was that they now know who it goes to. Like, they're not just delivering it to Roots and Roots just disperses it, but it's actually like they know the patients that receive it. They know the impact it has on the patients, and not just like, thanks for the lettuce today. But yeah, just the impact it has. And then the medical staff and CHWs actually having the resources and like referral process to be able to help patients when they say they have a need, such as like, I can't seem to get my blood sugar down, even though I'm taking the medicine that I'm supposed to be taking. And so, yeah, it was just another resource for them. And then patients actually know where their produce comes from and how it's grown and the different stories that come from the farms. Because a lot of the farmers are actually multi-generational farmers where it came from their parents and they just took it over. And yeah.
Yeah, and so again, we're listening for overarching successes for all of our food work. And the main one of the main ones is increasing access to fresh, culturally relevant, locally grown produce. And I think we've hit that mark, which we're really excited about. We're also witnessing the why, right? We truly believe food is medicine, and we have so many stories that kind of support that idea. I'll just share one story. It was during our COVID deliveries. It was a man who was kind of grumpy in the beginning, standoffish, and the CHW said, "Oh, here's your produce box." And they could tell that he wasn't happy, and they said, "Oh, well, how can I help you today?" And he's like, "Well, what I really need is someone to help me fill out this form so I can see my new doctor at Kaiser," right? And it would have been so easy for our CHWs to say, "Oh, sorry, we don't take Kaiser, that's not us." Or, "Oh, that's not my job, I'm just here to deliver the food." But they didn't. They met his need and they helped him fill it out. And afterwards, he was really happy. He said, "Oh, I'm going to take this mask that you gave me and wear it to my appointment." And that was it. And we thought that was the end of it. And that would have been a great story. But 2 weeks later, they were delivering at one of the public housing, and they went through, and the security guard ran up to them and he's like, remember me? And they're like, "Oh yeah, how are you?" And he's like, "You're the one that helped me to fill out that medical form. And because of that, I saw the doctor. And because of that, I got my medical clearance. And because of that, I got this job to be a security guard," right? And so it's this idea that when you never know what little thing is going to help someone take back their agency. And I think that's the dream for each of our interactions with patients, that this little tiny act can have a big impact. Yeah. And so I think that's our time. And obviously it's ending rather abruptly, and it's, I haven't finished the story yet. And I apologize for that, but we're really excited. We are, after this, we're going to continue to go out to people and talk to them and try and weave together that story. And I know everyone that's on this call listening, if you're working at a community health center, you guys have stories too. And I would love to hear from all of you and weave all of our stories together. And that's what really excites me. So thank you.
Thank you, Megan. I did want to, we have about 2 questions in the queue. I want to give you all about like 2 minutes to answer them. So we have Dawn who wants to know, Megan or Allison, do you use SDOH questions from a specific tool or have you created your own?
We base them off of, I think it's PRAPARE, but we've simplified it a lot. And like Allison mentioned, we weave it into a talk story. And so it is a Likert scale, like how we hit food security, housing, transportation, and I think there's one more, but I can't remember off the top of my head. And all of them are Likert scales, right? And so it's just, how often do you stress about having enough food or having transportation?
Thank you, Megan. And then these two are similar in the sense of, in terms of how do you financially sustain your food programs?
That's a good question. We write a lot of grants, that we're very grateful for all the organizations that have supported us along the way. But what's really exciting too is that we're starting to pilot a fee for service type of thing. And so it's with one of our local health insurance companies, and they will be paying us for every patient that we provide food for. And it's just a pilot, so it's 20 people, but our goal is that, yeah, that food is medicine and that it should be reimbursable through our healthcare system.
Thank you, Megan. And with that, we will go ahead and pass this over to our colleagues at ODFMC. And folks, continue to send your questions, whatever questions we didn't get to, we can definitely touch base with Megan and Allison and getting them answered for you all. Thank you, Megan and Allison, and now we'll pass things over.
Thank you, Chloe. Is everyone able to hear me?
Yes.
Go to the next slide, please. So, good afternoon, everybody, or good morning, depending on where you're located. I'm Karen Mandel. I'm the Senior Director of Community Health at Open Door Family Medical Center. I'll give you a little bit of an overview in a minute. I'm here today presenting with my colleague, Sarah Hodgson, who's the Director of School-Based Health Center Operations, and Leanna D'Agostino, who is our Program Manager for Wellness. So today we're going to just do a brief overview of Open Door, just to give everybody a little bit of a context. And then Leanna is going to talk about our Green Thumb / Food is Medicine program. And then Sarah's going to talk about an initiative out of our School-Based Health Center program around food security. Folks are saying I sound distant. Should I talk louder?
That's better.
That's better? Okay. I'm usually the loudest person, and I don't know why I'm talking so quiet today, so I will project. So Open Door is a federally qualified health center. We're located in New York State, just north of New York City. Our goal is to provide high quality health services to individuals in our communities, regardless of their ability to pay. You can see our values there on the left. I'm not going to read through them, but for those of you who are familiar with the patient-centered medical home model, these are very in alignment with what we work on for patient-centered medical home. Slide, please. Just a word about our patient population. Our patient population tends to be self-pay. So almost 50% of our patients are uninsured. Another more than 1/4 of our patients are on Medicaid. And then we have very small percentages of patients on Medicare, CHIP, or who have private insurance. Our patients tend to be very low income at 200% or below of the federal poverty level. We serve a lot of individuals who are recent immigrants to this country. Many are not eligible for insurance at all due to their documentation status, and the majority of our patients are best served in Spanish language. Next slide, please. This slide just illustrates the array of services that we provide at Open Door. Our main line of business is medical care, and we provide services to people throughout the lifespan. We also provide dental care, integrated behavioral health care. We have vision services, as well as podiatry and women's health. And then on the support service line, we have our wellness program, which Leanna represents. We have care coordination. We have our WIC program. And we have a variety of care management programs for our chronically ill patients. Next slide, please. This is just a snapshot of the Open Door numbers. The main takeaway here is just to understand the volume of the services that we provide. In 2022, we've served over 60,000 individuals. And we are expecting to serve more by the end of 2023. Please. So you can see here on the top left, you can see the map of New York State, and you can see Westchester County is not specifically called out there, but you see Long Island. We are that county that's weird, like Z-shaped lightning bolt, actually, I guess I would say, directly north of Long Island. And we do have a couple of locations even further north. One is just a dental practice and one is a school-based health center. So you can see on the map on the main part of the slide that we're located throughout Westchester County primarily. A lot of times when people across the United States think about Westchester County, their minds are automatically going to Scarsdale. I know all the time I see on Law and Order, they go to Westchester, they're going to one of two places. They're going to Scarsdale, and there are these huge houses, or they're going to Ossining, and they're not naming it, but that's where Sing Sing prison is. And so when you think about Scarsdale versus Ossining, those are two extremely different communities. And so hidden through this area of a lot of affluence is a lot of really vulnerable communities. And these are the areas where we focus our work, and these are the people who we serve. Next slide, please. This slide is just a snapshot of our school-based health center program, which, as I mentioned, Sarah will be presenting on a program out of school-based health. In 2022, we had over 6,000 children enrolled. School-based health is in 3 of our school districts. As I mentioned, 2 in Westchester and then 1 up further north. The beauty of the school-based health program is that parents don't have to miss work, and kids miss very little, if any, core subjects in school. There's also no out-of-pocket costs for the services received in school-based health. So it's basically a win-win. The kids get the medical care they need, they get their education, and the parents don't have to make a toss-up. Do I take the kid to the doctor for their asthma, or do I go to work to put food on the table? Next slide, please. All right, and so I'm done my introduction about Open Door. Hopefully that gives you a context and sets everything up for the programs that Leanna and then Sarah are going to speak about.
Thank you, Karen. I'm going to take over and talk about our Food is Medicine program at Open Door. So Food is Medicine is a food distribution and nutrition education program for our patients with a diagnosis of type 2 diabetes. We offer this program in collaboration with Feeding Westchester, a food bank for Westchester County. And MVP Health Insurance provides a grant to Feeding Westchester with the goal of helping to improve health outcomes by providing more access to fruit and vegetables, along with nutrition tips and recipes to people who are experiencing food insecurity, as well as chronic conditions. This grant helps to fund all of Feeding Westchester's Green Thumb programs, and Feeding Westchester chooses organizations like Open Door to partner with to meet these grant requirements. Green Thumb is the umbrella program under which Food is Medicine operates, and Green Thumb is offered more broadly to patients with chronic conditions and food insecurity, while Food is Medicine is now offered specifically to patients with type 2 diabetes. Next slide, please. So the history of Green Thumb at Open Door, we began offering Green Thumb in July of 2018 and continued through June of 2023 when we transitioned to offering our Food is Medicine program. Green Thumb, like Food is Medicine, offered fresh fruit and vegetables twice per month to patients with any chronic condition, with the goal of having the same patients continue participating throughout the entire program year, which is from July to June. We held 2 cohorts of 60 patients each year, one in Ossining and one in Port Chester. Each cohort was served twice per month at their respective location. When we first started offering Green Thumb in July of 2018, we had planned to offer the program as a food distribution and provide healthy recipes and nutrition tips on a handout. And based on participant feedback, we decided to incorporate nutrition education into the distribution. So we had our registered dietitians create some presentations and present them once per month during the distribution. We offered these nutrition presentations with our distributions until March of 2020, when we had to adjust to allow for a contactless distribution. And at that time, we turned back to relying on printed materials for nutrition education. Next slide, please. So transitioning to Food is Medicine and who is eligible. In July of 2023, we started our Food is Medicine program at Open Door. Food is Medicine is under the umbrella of the Green Thumb program, but it's offered specifically to patients who have a diagnosis of type 2 diabetes, as defined by an A1C lab test of greater than 6.5%, and the lab test has to have been taken within the 3 months prior to the start of the program. Due to some planned construction we had for our Ossining location, we decided we would serve 2 cohorts of 60 patients from our Port Chester location. Next slide, please. Volunteers and teamwork. So for each food distribution, Feeding Westchester delivers a box of fruit and vegetables, all separately packed, and they give us a slip indicating the amount of each item that should be packed into each individual bag that we distribute. With a small team in our wellness department, we rely on the help of our maintenance team and some wonderful volunteers and help from our community outreach workers. So the food is delivered on the morning of the distribution. Our maintenance crew greet the truck drivers and then move the boxes from the curbside to our wellness centers. Then volunteers come in and help put the bags together. Before that, our community outreach team makes weekly reminder calls to the patients. And this has helped immensely with the continuity, having the same patients return week to week. Additionally, the community outreach team will be offering presentations on mental health and wellness as it relates to chronic illness and to the patients in the Food is Medicine program. Tracking attendance, our wellness program coordinator and myself, we have been tracking all of the participants' attendance, as well as keeping track of their A1C and any updated labs like that in our electronic health, medical record. And we also have been keeping track for Feeding Westchester in their portal, which is called Link to Feed. Feeding Westchester also provided a pre-program survey for the participants, and we help the participants complete the survey and keep track of who's needing to fill one out. And then each participant will also be asked to complete a post-program survey at the end of this program year in June of 2024. Next slide, please. Food is Medicine addition of shelf-stable items. So in addition to the bags of fresh fruit and vegetables, the Food is Medicine program participants also receive a bag of shelf-stable items, which includes foods like rice, lentils, canned tuna, pasta, and shelf-stable milk. Our registered dietitians have been working with the dietitian at Feeding Westchester to create a list of items that would be that our dietitians would like to see in the bags for this population. This list so far includes foods like whole grains, beans, nuts and seeds, and spices. And now Feeding Westchester is working with a curator to try to obtain these items specifically for the Food is Medicine program. Next slide, please. Nutrition education and other program challenges. A challenge we faced was that due to the more specific requirements of the Food is Medicine program, it was a little more difficult to identify and recruit participants. Like we did for Green Thumb, we began by asking our providers to send direct referrals, but unfortunately they were trickling in a little too slowly. So with the time constraints for the start of the program, we did have to turn to calling and inviting patients from a report of eligible participants. Another challenge we faced was that due to not having a Spanish-speaking registered dietitian on staff, we had to hold off on offering bilingual nutrition education for the program. But fortunately, this past September, 2 Spanish-speaking registered dietitians joined our team, and we have now been able to start our nutrition education as of this month. We're still currently ironing out some strategies on how to increase our attendance to our presentations. So we started that by providing the community outreach workers with scripts for their reminder calls so they could communicate clearly with our participants. The scripts included information like the time of the program, the approximate length of the program, which is 20 to 30 minutes, and the presentation topics. Additionally, our team put together a short flyer with the same information so that we could give that out to participants. And another strategy we're considering is offering food samples at the presentations and possibly some small incentives. Next slide, please. Here are some patient testimonials. We asked our participants if they wanted to share how they felt about the program, and these were some of their sentiments. So we are so happy to be offering this program and continue to adapt and try to meet the needs of our patients through this program. And we know that they are really appreciating it, and we hope that this information is helpful. Thank you. I'm passing it along to Sarah.
Hi, thank you, Leanna. I'm very happy to be speaking with everyone today. We're in a new office, Karen and I, and so we're testing out the microphones in new echoey spaces. Is this okay? Awesome, thank you. I oversee the school-based health programs at Open Door. And in 2022, Open Door received a grant from Share Our Strength, No Kid Hungry, to strengthen food and nutrition security systems in Port Chester, New York. And it was focused within one of our school-based health centers located at Port Chester Middle School. We started by integrating a very basic food insecurity screening into primary care delivered through the school-based health center at Port Chester Middle School. There are about 1,000 students at the middle school. 85% of them are enrolled in the school-based health center, and they use the school-based health center for primary care, for their annual physical exams, chronic disease management, and sick visits. The students almost always come to their medical appointments by themselves without a parent, which comes with challenges for sure in gathering information from the students about their medical history or concerns, but It also gives us really wonderful opportunities to speak with students directly as the agents of their own health and well-being. And so as a part of this newer program that just started 2 years ago, we began asking students directly about their access to and behaviors around food. If a patient indicates that they might not have access to the food that they need, the medical provider can send a referral to our patient advocate, and the patient advocate can reach out to the parent, which they do, and they offer support and resources and engage the parent in more in-depth screenings and services according to the parent's interest. Next slide, please. We've also focused on the development of a network of partners within this community and within the school, so that as we receive our responses from families, from students directly, and then from their parents, we have a strong referral network. So we've so far screened 730 middle school students, and now we've also expanded that screening to the high school. 32% of them so far has been screened a second time. So typically that would be just during their annual well visits. So we haven't reached a second year for all students. So far, 8% of them have indicated with their responses that they might be experiencing food insecurity. And our questions to students are very simple, and it's really an experiment. I think part of what we've learned so far about that experiment is something that we may have suspected already, which is that parents do hide food insecurity from their children. They protect their children in that way. And so we may not be receiving as many kind of positive or responses about the likelihood of food insecurity in the home, but we move forward with what we have. So 82% of those agreed for a referral for follow-up support. Next slide, please. So we have a variety of partners. We've had a variety of partners since we began having, certainly Open Door overall, and absolutely the school-based health centers located in Portchester, which I think we're going on 16 years now. So some of the partnerships that we are relying on and strengthening for this newer program are new, and some are long established. We really look to develop our partnerships so that we can improve the success of referrals for non-medical services, and also to help our partners to reach our patients and reach other people in the community. One of the ongoing partnerships is between Open Door and the Portchester Middle School's Giving Garden. The Giving Garden was established 14 years ago. You can see the picture at the bottom of this slide with some of the students from last year. It was established by a consumer science teacher at the middle school named Allison Silverman, and she continues to lead the garden today with her everything, with her blood and her sweat. And we at Open Door began supporting the Giving Garden soon after it was founded, really starting by helping with grant writing to pay for supplies and paid internships and professional volunteer days. And over these last 2 years, we've been able to engage more deeply with the Giving Garden. We've hosted together mobile food pantries, where pantry staples are given away, as well as thousands of pounds of produce, all available free to families in the community. And we've continued to support the teacher who continues to lead the garden, and together we've employed multiple cohorts of middle school and high school students and their families to plan and implement events around nutrition security and food justice in Portchester. Next slide, I think, is just our end and our questions slide. So I'll turn it back to you, Chloe. Thank you.
Thank you. Thank you, Sarah. Thank you, Karen, and thank you, Leanna. I will go ahead. I collected a few questions as you all were speaking. So we're hearing a lot of questions, I'm seeing a lot of questions regarding financial support. So folks would like to know, are these grants typically federal, state, or local?
So on our end, the grant that supports the school-based health center program, I realized I was talking quiet again. that program, I believe, Sarah, that was a national competition, but it's not a government grant.
That's right. It's Share Our Strength, which is a nonprofit organization.
And then on the side of our wellness program, the staff that support the program on the Open Door side are not grant funded. And then Feeding Westchester as the food bank obviously has a lot of corporate partners on their side.
Thank you, Karen. Thank you, Sarah. So someone else would like to know, are participants provided sufficient amounts for their entire family, or are for the participants only?
Leanna, would you like to answer the question about the amount of food that's in the bags?
Sure. So each bag for our Food is Medicine program is only supposed to support the one participant who is in the program, but we also try to provide additional bags. We track household information. We know how many members of the household are there, so we can give more than one bag or extras to larger families.
Thank you, Leanna. And someone would like to know some more details regarding your giving garden.
Just in general about the garden itself.
Yeah.
It's like 25 by 25 feet. It's on a hill. There's groundhogs. One of the earliest fundraising efforts Open Door did for the garden was to pay for the building of a really substantial fence, because it was just my understanding. I wasn't part of the program at the time, but when it first started, like every year was just a battle with the groundhog. So it's slightly raised beds. I think what is interesting about a garden that's affiliated with a school is that if school staff are the ones leading the charge, and if the school district agrees to kind of cost share with the garden to pay for the staff time, the fundraising that's required to maintain, a relatively small garden. It's not a farm. It's not meant to feed all the students in the building, but relatively small amounts of money can pay for the supplies, like mulch and seeds and compost before the garden starts producing its own compost. Places like grocery stores have given small, $5,000 and have very few requirements, unlike, a state grant or a federal grant that would require so much, which, kind of couldn't be done by the staffing of the garden if they were teachers in the building. They grow a variety of things, tomatoes and peppers, a lot of chilies, things that are interesting and relevant for our families. Greens, blueberries, snap peas. There used to be 2 fruit trees, which were very productive, but also because the Northeast there was like a lot of pest pressure. Was that the kind of details that you were looking for? Maybe a mock base. It produces over 1,000 pounds of food every year, but again, being in the Northeast, and I guess everywhere now, the weather is very really, it's unpredictable how much can be produced from the garden.
I can add things to that as well. So one thing that I thought was a really cool strategy regarding the teacher who oversees the garden is that we went with her in support of her, and she advocated that she was paid as a coach over the summer. And so the school district went for it. It's not a big amount of money, but they have money for coaches. And so she was able to incorporate the garden as part of her role. She's the consumer sciences teacher, which is code for home economics. That's what they called it in my day, but it's consumer sciences now. And so that's part of her role during the regular school year. And then in the summer, we were able to get her, a small, stipend as a coach, and that really helped. And then the question was, well, she can't do all the upkeep of the garden on her own. And we actually got a couple of small grants to have high school students who were formerly her students when they were in the middle school be garden interns and help with some of the activities, the upkeep of the garden, the harvesting of the food. And they actually made these little applications, and she supported them actually in terms of like writing a resume and a cover letter. So there was that additional component. And so we've been able to help support some student interns. They donate a lot of the food, as Sarah said, to food pantries in the summer. And we've done different iterations of having more families come in the summer to help with garden upkeep. And when they help, they're able to leave with more food. There's definitely been some interest with some of the corporations in the area who like to do volunteer days. So they've come in and done big cleanups, and sometimes that leads to some additional money as well. So those are a couple of the other strategies. You know, as Sarah said, this garden's been around for many years, longer than both of us have been at Open Door, in fact. And there's been a lot of different fun strategies, but because of what they've been able to do with the school support, it's really maybe a few $1,000s a year, if that, for the general, you know, seeds and tools and so on.
Thank you, Karen. Thank you, Sarah. Thank you, Leanna. With that, go ahead and take Karen's information, which is listed on the screen for you all if you all have any additional questions. I apologize, but this was such a great Q&A session, but I do have to wrap it up in terms of some additional announcement that we have for you all. But we're grateful to all of our presenters. Thank you, Megan. Thank you, Allison. Thank you, Sarah. Thank you, Karen. Thank you, Leanna, for such a great presentation. I did go ahead and drop Karen's email in the chat, as well as Megan's email, in case you have some additional questions. And with that, I will take us to our additional announcements for you all. So NACC is launching a health equity learning collaborative. The goal of the NACC's Health Equity Learning Collaborative is aimed at exploring how health centers are utilizing social drivers of health data, patient and community voice, and community partnerships to advance health equity. We actually have an application open right now. It actually closes January 26th. I did go ahead and supply you all with the application link. And if you have any questions, please feel free to reach out to myself, Chloe Destinovo, and my email address is also linked in the chat for you all. And with that, thank you to all of our panelists for taking the time out to provide this presentation, and as well as sitting through our Q&A. So now it's time for you all to, as our participants, to let us know how much you enjoyed this presentation. So please feel free to scan this QR code and complete a brief evaluation for you all. So please go ahead and do that. And I will go ahead and drop the link in the chat for you all in case that is easier for you to access that way. And with that being said, we've reached the end of the presentation. Again, thank you to our wonderful panelists, and thank you to all of our attendees for sticking through and hanging out with us today. Have a great
Bye. Thank you.
Bye. Thank you all.